All right, while everyone's sitting, good afternoon. I'd like to thank Sharon and the Genetic Alliance for putting together such an excellent workshop here today. My name's Emily Edelman, and I come to you from NICHPEG, the National Coalition for Health Professional Education in Genetics. And this session focuses on identifying goals, challenges, and potential approaches towards collecting the clinical utility data needed to determine evidence for genetic and genomic tests. And when I first sat down to think about this session and thinking about how do we collect the data, it raises the question, well, what data do we need? And in turn, well, what outcomes are important? And it comes back to the questions that we've been talking about throughout the day today. What is the evidence that we need and how do we collect it? And my position is that we think about clinical utility from a number of different perspectives, and I think we've touched on most of these today. Certainly, I'll call it the traditional, for lack of a better word, or maybe most strict interpretation of clinical utility would be that the test impacts, preferably improves, patient medical outcomes. So what is different about this patient's health outcomes based on this test? We've also talked about the idea of informed decision-making as a utility of genetic tests and reproductive decision-making for an individual or for a couple. We've talked about, a couple of panelists have touched on the idea of personal utility, that aside from any direct medical benefit, the test or the result can be valuable to the individual for whatever reason, X, Y, Z. And then perhaps this touches on the first three things that I just talked about, but my last point would be to continue to think about the utility of testing for family members, and we've certainly talked about this today. So, and one other point that I just wanted to emphasize, we've talked about context, which I really appreciate. Multiple people have brought up context of clinical utility and context of genetic testing throughout the day. So the clinical utility of a genetic test depends on the clinical scenario of interest. So for example, if we are talking about testing positive for hereditary cancer syndrome, like MLH1 or BRCA1, whether or not that individual is 20 years old or 80 years old, or whether that individual is male or female, or has cancer or is unaffected, all of those different clinical scenarios impact the outcomes of that genetic test. So the outcomes are different depending on the clinical scenario. Therefore, the data is different that we need to measure. And perhaps even the data collection instruments are different depending on these different clinical scenarios of the individual. So to consider the charge of this panel, thinking about real-world clinical scenarios for collecting clinical utility data, our panelists will consider these outcomes that we've been thinking about. What are the outcomes that are important for demonstrating clinical utility? What are the data that we need to measure clinical utility and generate the necessary evidence? What are the available data sources that we can use to pull data from, like the EHR? What are other existing models that we can use to collect data? What policy initiatives are needed to support our data collection efforts? The challenges and potential solutions that we need to consider to achieve this goal of collecting data towards evidence. And last but not least, what we already know and what needs to be studied regarding the patient perspective and patient preferences of collecting data and outcomes. All right, so with that, let's get started on the list, and we're just going to go straight to Marc Williams from Geisinger.
Great, and I'm going to actually present information related to a specific disorder that Dan had referenced earlier, Lynch syndrome, and this was work that we had done at Intermountain. We became interested in this because of the EGAP publication and subsequent cost-effectiveness publications that showed that tumor-based screening for Lynch syndrome was cost-effective if relatives were identified and enrolled in surveillance. I think one thing that we undersold there is there's also benefit to the individuals who actually present with cancer as well, but which hasn't been factored in as much, so just as an editorial aside. So when we looked at developing a system by which we could implement this in a consistent and coordinated fashion, one of the things that we did was develop a list of outcome measures, and some of these were process outcomes, some of them were medical outcomes. Some of them involve patients, and some of them involve relatives of patients. Some of the examples would be just a basic monitoring of the screening process, follow-up data to say of those patients who screened positive, how many of them presented for counseling, how many of them had confirmatory testing. For those that had a mutation confirmed, how many relatives were able to be contacted, and of those, how many were tested, et cetera. The effectiveness of screening, at least from a cost perspective, is in part related to how many will in fact complete the confirmatory testing process and then use that information. And once you identify the mutation carriers, then you can track some process and medical outcomes such as compliance with, say, colonoscopy recommendations. Are they starting at an earlier age, doing it more frequently? How many polyps are being removed? Are cancers identified? If so, at what stage? Are people taking advantage of prophylactic surgery outcomes of women, for instance, to have a hysterectomy, oophorectomy to reduce risk for endometrial and ovarian cancer? Now, that's the easy part. Defining the outcomes is really easy, but collecting them is challenging. Now, we were able to, within our electronic health record system, with some amount of effort, developed a mostly automated dashboard that tracked all of the colorectal cancer patients through the screening process. So every single patient that came into our system with the colorectal cancer, we could tell, was the tumor screened, at what point in the screening were they, what were the results of each of the screens, did they get appropriate reflex testing, et cetera, et cetera. And so we were able to get a weekly dashboard report on that to make sure that we weren't having any system breakdowns, and we actually identified situations where there had been a change in a pathology department and suddenly the screening dropped out. We were able to get that ramped up again quite quickly. And we also had the ability so that all screen positive patients were referred to one genetic counselor. So we had a choke point of information there. At that point, though, the counselor had to manually keep data on the number of those patients that actually presented for counseling, the number of them that consented to go forward with testing, that received their results, and then how many of those patients then contacted relatives, how many relatives, et cetera. There's no way to collect that data out of some type of a record system, even though a number of the relatives were actually followed through our system. It's time intensive. We had relatives that we identified that were all over the country that we had to refer to other centers. So at least for the mutation carriers that we identified that were in our system, we could set up an automated surveillance where we could look at colonoscopy, polypectomy, surgeries, et cetera. But we really couldn't automate that outside the system, and in fact, unless people were willing to share that data, we couldn't do anything. So this comes back to a major issue that was highlighted this morning, which is the ability to aggregate data outside of an individual system. And I think it's also important to recognize that Intermountain as an integrated system is one of the few systems in the country that could actually even have done it at a system level. So if we want to rapidly increase our knowledge, we have to be able to aggregate both phenotype and genotype data, and I won't beat that horse, other than to say there's a heck of a lot of barriers. But the power, if we're able to do it, is quite immense. Even with 1 year of data, we were able to confirm our cost assumptions from our model, and we actually showed that the screening process as implemented was less costly than we had initially modeled. We were able to define the cost impact to each of our system hospitals. We were able to address a question in the literature, which is, well, should only individuals under a certain age be screened, or should you screen everybody? Using our data, we were able to show that while using an age cutoff reduces the cost of the screening, it dramatically reduces the sensitivity of the screening. And to get to a point that Emily made, if you eliminate your 70 and 80-year-olds from the screening, those individuals have a lot more relatives that are potentially affected. So the downstream impact of missing those patients may, in fact, have a much higher consequence than missing a younger person. The second point that I think is important to take away is something that hasn't been talked about today is we need to take advantage of the use of decision modeling and economic analytic strategies to take data that we have and to use it to answer very important questions. And this gets to a point that Dan made this morning. If Heather Hampel and the Ohio State group hadn't been willing, A, to publish their data, and B, share it with us when we called them repeatedly and say, could you tell us how many patients are in this category, we could not have populated the models. We couldn't have made a compelling case to our system leadership to say, we think this is an important thing to do for our patients, let's go ahead and implement it. So I think we really have to figure figure out how we're going to do that. And I think the scaling issue, how do we do that on a national and international basis, is a hugely complex question. But in my view, if I had to plant my seed for Adam, that's where I would plant it.
Thank you. Next we have Bruce Lynn from the March of Dimes.
Thank you. So I'm going to take a little bit of a left turn here. I'm going to bring up an old friend, which is family health history, and family health history as a genetic test based on what we've talked about today. Family health history, the idea is that it could give us context in why a genetic test was ordered, and eventually with the whole genome-wide sequencing, it could give us context for those variants that we don't know the clinical utility of yet or the validity yet. I have the pleasure of working, March of Dimes has the pleasure of working with Genetic Alliance, NICHPEG on a HRSA collaboration, also Harvard partners. And what I'm going to talk about is our approach to taking the family history and how we can use the family history in the first prenatal visit. So the project really is to develop, and we implemented an electronic tool that helps primary prenatal care providers identify patients that they see at higher risk for genetic conditions that would require subsequent management that includes referral or ordering a genetic test. And the way we approach this is this electronic tool, the patient enters their medical and family history information in the waiting room or a little off the waiting room into a tablet PC, and they, at the moment that they're done with this survey, behind the scenes, behind the office staff, the printout, this patient report is generated. And in that patient report is where we've built in the clinical decision support. And that decision support takes, it's pretty simple. It's 3 columns in the patient report that says what the syndrome was that this patient's at risk for, what the action is, and the reasons for that action. And so within the actions, those are built on algorithms that we reviewed with existing clinical guidelines, ACOG, NSGC, ACMG. And those, I'm recalling a comment from earlier, sometimes it was hard to make those guidelines, those narratives, into machine-readable algorithms. But we did the best we can, and I think very true to those guidelines. And that is the basis of our decision support. And I think this software is going to be freeware, but I think about the future of data collection and how others can use decision support. One of the ideas is to develop a web service so that any EMR that wants to push out their data, the structured data, could come to this web service and use these algorithms, existing algorithms. We would push back these same decision support. So you don't necessarily have to install this freeware in your own system, but that is one way of collecting and using this data for decision support.
Thank you. Next we have Matthew Tector from Aurora Healthcare.
Thank you. So Aurora Healthcare is a community provider, which I think really, the statistics out there say about 80 to 85% of all patients get treated in community providing facilities. And I worry, not worry, but I start to wonder if that perspective is really present enough in settings like this and others that talk about really the next wave of medical information, where you have the academic centers which have the funding and can really drive some of these advances, but when you look at when it comes time to implement them in settings like ours, it's a head scratcher for us in many regards. And the reason we started the project that I now direct, which is a biorepository, is when you look at genetic testing, we were always at arm's length. We're never part of that development or discovery process. And then we really don't have a way of figuring out when do we implement something, when do we not implement something, and we're always relying on the source of data I'm actually interested in talking about is really published literature. We have our own diagnostic lab. They'll go out and read journal articles and say, gee, this one looks interesting, that one looks interesting, let's think about offering it as a diagnostic test. On the flip side, we have our clinicians, and those two are not tied together when the discussion occurs. And that's something we're working on, which is you'd think it makes sense to have the people who'd order and act on the test information integrated keenly into that decision-making process in terms of when do you offer something and things like that. So what we've been working on is setting up our system to consent patients across the system that will allow us to access their medical records and their diagnostic blood samples to let us start to get a feel and really just get our feet wet for what does this all mean to us, and really hopefully help us go in and take the full advantage of the vast majority of our system, the information in it, so that we can start that modeling type process. If we were to implement this test, we can go back and look at, run that test on the bank samples we have and try to help the business side of things understand what what adding a new test may mean, how that may impact not only business operations but outcomes. But on the flip side of that, one of the huge challenges we have in a setting like ours is some of our clinicians are so busy, a patient visit is 2 minutes. So if you think about trying to suddenly get them to think about genetics in that setting, it's a real challenge that we're experiencing. We're also offering a course system-wide where we try to get our clinicians free for an hour a month, which we're not being very successful at, to come in and learn about just the advances in genetic testing. It's a real struggle for us, and we're hoping that by being able to offer information from their own patient population, it starts to get a little more traction with them rather than just being something that they kind of read, at arm's length from journal articles. And that's one of our big issues, and that's where we're trying to go. But it's something that I think, the community providers really need to start thinking about what's the right way to jump into this game and when, and then, where do you offer the test, point of care, centralized facility, and then again, which ones do you do? And then the other thing we're learning from our project, which is our hospital. We have a hospital in the downtown of Milwaukee, which makes us the largest provider to the underserved community in Wisconsin. And the big challenge we're finding out there with trying to consent through our population at large is participation in the underserved medical community is extremely difficult. And when you talk about the gap in providing medical care, we're at real risk of widening that gap if we don't figure out how to you can't fix something if you can't study it, is our motto. So how do you get participation and all that from that community so that you really can include them and ultimately offer them the same level of care that the better served communities have access to? So those are the two issues that we're keenly trying to approach. Thank you.
Thank you. Next we have David Ledbetter, also from Geisinger Health Center.
Yeah, I'm going to speak today from a diagnostic laboratory perspective. My own training and background's in cytogenetics, and we went through a tremendous revolution in technology in cytogenetics starting about 5 years ago when it became possible to do whole genome microarray and identify smaller and smaller deletions and duplications in children with developmental disabilities and autism. But when we did that, we increased the clinical utility and diagnostic yield of molecular cytogenetics compared to karyotype, but we also identified structural variants where we didn't have sufficient evidence in the literature on what the potential clinical significance. So it became a problem of sorting out what's a known pathogenic copy number variant, what's a known benign copy number variant, and then we had a large bucket of variants of uncertain clinical significance, similar to molecular diagnostic sequencing. So in 2007, my colleagues and I at Emory at the time started a consortium of clinical genetic testing labs under the notion that any one lab was not going to obtain enough information, empiric data on phenotype and genotype to determine what the functional variants and clinical significant variants were, so we needed to share data across many labs, and that's been a successful effort that's now over 160 labs that contribute diagnostic clinical information and whole genome microarray data through dbGaP at NCBI NIH that goes into dbVAR. Unfortunately, there's often not detailed clinical phenotypic information, just a diagnostic code. So we're still making efforts to improve the richness of the clinical phenotypic information. That's part of my decision to move to Geisinger in Pennsylvania, where there's a rich clinical database related to the EMR data, but then a clinical data warehouse to increase the power of taking clinical data available free as a byproduct of clinical care, and now more and more powerful genomic data free as a byproduct of clinical genetic testing on a fee-for-service basis. So taking this model of a learning and sharing healthcare system, so we need to add sharing to the description of learning healthcare system. If we pool data across many laboratories and across many healthcare systems, it will accelerate our ability to understand the clinical significance of variants. If we move now to sequencing, all discussions about next-gen sequencing and whole genome sequencing are very intimidating when you think of the problem as sequencing the entire genome and interpreting the entire genome. But in fact, you don't have to start with that perspective. You can take the tremendous experience we have now with sequencing one gene at a time and just say it may be cheaper soon to sequence the whole genome and then look at one gene at a time when it's clinically appropriate to do so. I was at a conference a little over a year ago, NIH genome-sponsored conference, and the topic was, when will it be cheap enough to sequence the whole genome on every baby born in the United States as part of routine newborn screening? And of course, everybody was concerned about the cost and difficulty of interpreting the entire genome. But of course, over the course of 1.5 days, we came to the realization you don't have to analyze and interpret the whole genome. We only have follow-up programs in place for 30 rare genetic diseases. If it's cheaper to generate the data on the whole genome and only look at those 30, that makes sense to do it now. So as soon as the costs come down. Some people worry if you generate the data, you have to look at it. But right now, in all molecular testing, we get a tube of blood or other tissue. We have, in fact, the entire genome. But we're only asked to look at one gene. And that's what we do. We look at and report one gene that's clinically relevant. People now are implementing whole exome sequencing on a clinical basis. I have a little bit conservative approach to this. We estimate we have 23,000 genes in the human genome, but unfortunately we don't know what most of them do. So analyzing and interpreting them is a research problem, not a clinical problem. If you look at OMIM, there are 3,436 genes that are tied to a disease phenotype. So there are only 3,400 diseases with a known molecular basis. Analyzing those would be a clinical test. Analyzing the other 20,000 genes is a research project. That's my timer, so I'll stop there.
Very good. Your moderator approves. All right, and then next we have Eric Stanek from Medco.
So I'll be here representing a group that I think is underrepresented. I think I might be the only pharmacist here, and that's something that has not been part of the conversation. So I'm going to come at this from a pharmacist perspective and specifically from a pharmacy benefit management company perspective as to what we specifically at Medco have done to sort of kickstart pharmacogenetics and applications of pharmacogenetics in practice that's built primarily around a pharmacy platform. And we talk about EHRs and EMRs and wiring. Pharmacy is wired already. You can go anywhere in the US and get a prescription filled, and we know it, right? And we can find out if I want to for Medco membership, which is 65 plus million people. And we're still Medco, by the way. We haven't been acquired just yet. But I can sweep through that data on a daily basis and find people who are new to therapy X and do that on a really within a 24-hour period. So if there's an opportunity to do something around that prescription or the decision to place somebody on that therapy, if there is a pharmacogenetic test that might be applicable, we decided 4 years ago to start some clinical testing programs that are remarkably simple and quite unobtrusive, and actually were created to provide access and choice and convenience for physicians and prescribers and patients alike who may be eligible for genetic testing with regard to certain therapies. And we started with warfarin, with 2C9 and VCORC1 testing. Say what you want about it. We started. And we also started with 2D6 testing for tamoxifen. And Basically, we're Switzerland in that what we have done is taken an approach of we first set about vetting which tests we wanted to offer, and so we chartered an independent laboratory and therapeutics committee that's made up of external people, experts in genetics and laboratory science and pharmacology and medicine from around the country. And they vet the assays and their application and the analytic validity and so on and so forth, and they make an independent recommendation as to yes, you can consider offering this test, or no, do not offer this test. And then the question was, well, how would you get people to pay for it? And insurers, as you know, health insurers don't typically want to pay for these things without a lot more information. So we designed a process where it's actually managed directly through the pharmacy benefit. So we've taken these testing programs directly to the payers, which are health plans, employers large and small, government plans, retiree plans, and talk to the medical directors or benefit directors for those organizations. Provided them with the choice of allowing patients who are prescribed these therapies to be offered this test, and if they say yes, it's basically a fee for service negotiation for them to pay for that test directly through their pharmacy benefit. So what the prescriber sees and what the patient sees is offering of a test that does not cost them anything. And the way the process works is when a patient is identified, the physician is actually contacted through a variety of means. Some physicians we already have a good relationship with, and they want to hear from us by fax. Others get a phone call from a pharmacist. They alert the physician that, hey, your patient who you just prescribed warfarin to has this benefit available to them. What do I have to do? Well, you just have to decide if you want to order that test. Well, yeah, I do want to order that test. Okay, well, then a lab order is faxed to them specific to that patient. They have to sign that lab order, submit that back to Medco. That gets, and then once we have that, we also contact the patient and let them know that they're eligible for this test, that their physician has agreed and ordered it. Do they want it? Do they want the test? They have a choice in this as well. And patients will have a variety of questions, and sometimes we'll say yes, or sometimes we'll say no. And if they say yes, then a cheek swab kit is sent directly in the mail to them. They can complete it at home. If they need support, need some help, they can call a number anytime and talk to a real person who can help them through it. That test then goes, the kit gets returned by mail, postage free to the patient, directly to the testing laboratory. So we have a partnership with a national testing laboratory. Gets married up with the order, and the test is run, and the results go both directly to the physician and also into to Medco, and becomes part of their pharmacy record. So that information exists as part of their pharmacy record, and has dual purpose later, in that based on their drug metabolizing enzyme, for example, 2C9 or 2D6, depending on the situation. If they are later prescribed a drug for which that is important, we have drug utilization evaluation programs that run, and will notify a prescriber if they may want to, if they don't know that information, they may want to consider that in their therapeutic therapy decision, and sometimes these things are altered. So what we've done over the last 4 years is create a very large database of patients and prescribers and for some specific tests, and we've learned a tremendous amount about what works and what doesn't work, and we've changed the process with a quality improvement approach over time. We're able to track what the impact is, what changes in therapy are made in response to that information. As we're accumulating more information over time to be able to actually track some additional clinical outcomes as well. So I'll stop there.
Thank you. So now we will take questions. If people would like to come up to the microphone, and I will get things started. So I particularly liked this panel because people were talking about models for implementing, either in a research or clinical setting, different genetic testing programs. And so I find it kind of stubbornly concrete, and I like having these examples. And we talk a lot about barriers to implementation and barriers to integration, but we have here some very rich experiences of programs that seem to be working. So I'd like to hear perhaps if you could highlight a facilitator, something that has helped support your program or really been critical to the success of your program.
Quite honestly, we couldn't have done what we did if there hadn't been 25 years of cultural change at Intermountain around quality improvement and systems thinking. And this is a real problematic issue. It relates to what Reed was talking about, crossing the quality chasm. He indicated that this is not a physician problem. What he didn't finish off and say is that it's the problem with our systems not interacting and not thinking about how we really need to affect change. Systems are perfectly designed to deliver the outcomes that they deliver. Our healthcare system is perfectly designed to get our decisions correct with a coin flip. We operate at half a sigma. I don't think we would fly in airplanes if they operated at half a sigma. It's ridiculous. So the systems that are investing in this type of a cultural change then have a lot of those cultural barriers to change have been eliminated, and it makes it somewhat easier. Now, there's generalizable knowledge around that, and there's a science now of dissemination and implementation. And in a shameless plug, next week here in Bethesda, there's the 5th annual Dissemination and Implementation Science Meeting that is funded by NIH that's going to be held at the Marriott North. For the very first time, there's going to be a genomic session there that we're going to be presenting 3 different people, a pharmacogenomic example, a family history example, and then the Lynch syndrome example in the context of dissemination and implementation science. So this is something, and I think it speaks to what Matt was talking about, we need to develop generalizable knowledge around the science of actually being able to do this. And fortunately, I was in a situation, chose to be in a situation where there was a permissive culture.
So I would say because this project, the Family Health History Project's implementing a electronic software, I think the key facilitator would be that champion. It's classic. Someone who believes in the project, someone who's going to convince the IT department that even if they're integrating into a new EMR, that this is about quality improvement. That champion could be a genetic counselor or lead physician or the department head, and little things that, like comparing, well, this is what we were doing on the paper form, and it's really no different than what the questions we're asking in the electronic tool, to, again, just getting the IT buy-in. So it's really about the champion.
If I could just expand real quick, I think one of the biggest things we've learned is that if you've talked to one payer about their take on things, you've talked to one payer. And not all payers are the same, and not all decision-making processes within each payer system or type is the same. And what we've learned is that, quite frankly, if you ask them if they want something, they'll give you an honest answer, right? And they'll ask the usual questions, well, how much is it going to cost me, and is there a downside? And you give them honest information about what you know and what you don't know, and let them make a decision. They'll make a decision. Same thing is true with healthcare providers, and I think a comment that Matt made about community physicians, and warfarin is a great example. The vast majority of patients on warfarin, about half of warfarin is instituted on an outpatient basis in the U.S., and about 80% of those patients are cared for out in some community setting, and they don't always have access to these things. And if you provide it to them, along with some support and other resources, and you make it halfway convenient, they'll do it when they think it's clinically appropriate, and when they think it's not clinically appropriate, they'll tell you so. And lastly, the same thing is true with patients. If you give them enough information to make a decision, and whether or not they want something, and regardless of whether or not, by the way, if their physician said that they would like to do it, they'll still give you an answer. So, I think we've learned that if you ask, people will give you an answer, and I think that's tremendously helpful.
I've been pleasantly surprised over the last 4 years in this collaborative project among clinical genetics labs to find that most clinical lab directors are not like human genetics researchers, meaning they don't feel like they own the patient data and that they need to keep it within their lab. Instead, they feel it's very important to improve patient outcomes, improve the quality of laboratory testing through sharing their data as soon as they get through various IRB and institutional obstacles. And the only criterion is that we make it as easy as possible so that it doesn't disrupt their busy clinical workflow. And the vendor community has been very helpful in creating software to automatically or semi-automatically submit data to NCBI dbGaP project. So it's been very rewarding to see that attitude among clinical lab directors different from some of our experience with the research community in terms of data sharing.
Okay, great. Well, let's take a question over here.
Yes, I have a question regarding clinical utility, regarding the different disciplines. It seems like there might be disparity in what that might look like from the patient's perspective, as well as is there any kind of differences associated with processes to determine clinical utility for prenatal, newborn, and issue-based testing?
I think in some ways Potter Stewart said it best, to paraphrase him. Clinical utility, I can't define it, but I know it when I see it. And so in some ways, we know clinical utility when we see it, and it does depend on our perspective. So a clinician's perspective will be different from a payer perspective. The type of clinician, a geneticist versus a primary care physician, will have a different perception. And then I forget, I think it was Holly that mentioned the idea of this concept that's just beginning to develop of personal utility, which is what does it mean to me as a patient to know this information? And that's a perspective that also has to be taken into account. It's not to say that all of those perspectives are valid or are based in evidence, but I think it at least frames the different questions that we have to be asking when we try and say what is the value of doing this. If we don't look at all those different possibilities, then we could very easily miss an important aspect that would define the value of a given intervention.
If I could just expand a little bit on that, and you know, I guess I'm a believer in in empowering patients and the whole concept of personal utility, because the beauty of it is only the person can define it. And we've actually looked at this specifically in a context of some research studies that we've done, where we enroll patients into a specific research study that involves genetic testing in the context of drug therapy. And then we sort of try to decompose their decision around why they participated. And the overwhelming answer for those who, roughly 60% of the time we find, is that when people choose to be part of a research study that involves a pharmacogenetic test, and it's all about the pharmacogenetic test and what it does with how it changes their behavior, for example, for adherence to medication, is because it might help me or it might improve my health, and it's a big might. But so I think that speaks a lot towards the fact that there's a supposition, at least in the people who are willing to do this, that there is some modicum of a chance that it might benefit them in some way, and they're happy to do it.
Yeah, and I think that I would certainly agree with that. The issue, and this is an expansion of a point that I made a little bit earlier, is that in some ways, as individuals, we have a perspective that is important, but we also have to reflect the fact that we don't have an infinite amount of money to spend on healthcare. And so, again, there's surveys that have shown that if you ask any individual, they say, yeah, there's too much money spent on healthcare. But if you ask them, what are you willing to give up in terms of your healthcare? Nothing. It's everybody else. So, it's that typical sort of situation that is not unsurprising. So that's why I think we have to, as much as we need to bring personal utility into the equation, I think it also has to be balanced with the societal problems that were outlined earlier.
Okay, we're going to have time for one more quick question.
Oh, thank you. Judith Benkendorf, American College of Medical Genetics. And I'm going to break your microphone, too. I'll just hold on to it, then I won't break it. All right, I wanted to really thank this panel for, I think, making a very nice bridge from what we heard this morning. At the end of the morning, I was feeling a little bit overwhelmed, and I think many of us were. Now we're hearing that the pace of data generation through research and translation has never been faster. It's never been at a greater heterogeneity of sites. It's never really been a greater heterogeneity of data at a greater volume. And yet, Susan Friedman, I think, made the point, well, what about the patients? What does this mean for the individual patient? And what does this mean in terms of outcomes? And I was taken back in time and to actually the last century. And that was to the biobehavioral and LC research that went on with both cystic fibrosis and hereditary cancer testing. And that was that 10 LC grants were awarded for cystic fibrosis testing, and it was all genetic services offered in clinical trials, and then another 10 grants were offered for looking at the integration of BRCA1 and 2 and also colon cancer testing, again, in the rubric of clinical trials. So services were being offered through clinical trials. And the beauty of that was that the NIH set up a Cancer Genetic Studies Consortium. So all the investigators got together and pooled their data and talked about their experiences and what they've learned. And it turned out to be extremely rich, extremely robust, and really accelerated the process and what we knew. And I think it made us all feel much more comfortable about bringing this new testing, which was pre-symptomatic, and for the first time it was testing where a negative test result, of course, didn't mean you weren't going to get a very heterogeneous common disease. There were residual risks, there were relative risks involved, all of the same things we're seeing moving forward. And I guess I would just like to put in a plug as we come up with recommendations for this conference that we don't throw away the biobehavioral and the LC research, and we talk about ways, even if the research is coming out in a much more multi-centered, heterogeneous way, to be able to take some of that research that can really translate to the clinical setting, to the bedside, offering services through research protocols, and pulling it all together by bringing together consortiums of investigators to accelerate the process. Thank you.
Excellent points. Thank you.